Hello, I'm Nicolas Mottet. I'm a French urologist and I'm so far the chairman of the guidelines for prostate cancer at the EAU.
Dr. Mottet, we're here at the EMUC conference, and one of the major topics is predictive diagnostics. There are many new tests out here, but in your opinion, what do they mean?
Well, they are of interest, but I would say probably not immediately. They raise several questions, and the question might be different. What are you expecting from that? To avoid biopsy, or to decide to go for a biopsy in a situation where you wouldn't have done that? If the tests are there to avoid biopsy, it's fine. And then there are a lot of questions. If you avoid a biopsy, you avoid a biopsy based on what? What do you want to avoid? To find insignificant cancer makes sense. How do you define insignificant cancer? Is it just Gleason 7? That's perfectly fine. Is it Gleason 6? Probably the data are not so clear. Avoiding to find a very low volume Gleason 6 makes sense. Avoiding to find a high volume Gleason 6 probably is a little bit different. If you are 50 years of age, high volume Gleason 6 might be dangerous on the very long term run. On top of, so as long as you haven't very clearly defined what you will avoid based on a test, it's difficult to recommend it. Second, if you want to go for a biopsy in somebody you would not have considered for having a biopsy because of PSA of 2 and a normal DRA, there's absolutely no guideline suggesting you should go for a biopsy. If the test is positive and suggests a very high risk to find aggressive disease makes sense, then that would suggest to use the test for everyone, which is probably not the right way to go. Then you should select populations at risk. Must be done. And finally, two other points. The first one is there's an ongoing trend to suggest that MRI, multiparametric MRI, might be a very useful way to select patients with significant lesions in terms of volume. How do the predictive test, interfere with the MRI? Nobody knows because it has never been studied. And finally, if the primary objective is to avoid unnecessary biopsy, the extra cost of the test has to be balanced between the for free available tool we have so far, such as the RSPC calculator of any form of nomograms externally validated. Roughly, if you use an RSPC nomogram, you avoid roughly 30% biopsy. With all the tests I'm aware of, you avoid the same amount of unnecessary biopsies. One test, you have to pay for it. The other one is absolutely for free because it's based on PSA, DRA, prostate volume, previous history. You all have this before giving a test. So the tests are probably very great. Are they really useful? I'm not absolutely convinced, and I can tell you in the guidelines they are not level 1 evidence. They are far away from level 1 evidence, and we just say you might consider UE something, either a nomogram or a calculator, a risk calculator, or a test. And that's it so far.